Hi, everyone. I'm Donna McKay, the Executive Director of Physicians for Human Rights, which is PHR, and I'm thrilled to welcome you to our speaker series, which is dedicated to the discussion of pressing health and human rights topics and implications of the COVID-19 pandemic. For those of you who are new to our series, since the very beginning of the pandemic, we've gathered leading national and international voices in health equity, human rights, science, medicine, research, as well as voices from the front lines to lead us in conversations on a host of critical issues and challenges that this global health crisis has laid bare. We, PHR, have been an important go-to source for science-based information and human rights-based approaches. And these conversations have been an important vehicle for information and also for forming partnerships. As we all know, we're living in a period in which scientific and medical communities are experiencing some of the greatest innovation and achievements, such as the development of mRNA vaccine technology. But at the same time, the pandemic's also revealed the crippling damage to public health systems that's been caused by decades of underfunding and deprioritization, as well as gross inequalities in our systems. In the US, public health officials whose job it is to protect the lives of millions of people from COVID-19 have faced violent threats in response to recommended mask mandates and other safety precautions, not just from the individuals they serve, but also from our government officials who've embraced an anti-COVID, anti-science platform for political gain. More than half the states in the US have advanced measures to limit the authority of officials tasked with protecting the public's health. And as a result, an already chronically understaffed public health system has seen the loss of more than 300 leading local officials since the beginning of the pandemic, one of whom you will hear from today. So I'd love to get started with this conversation. I am really excited to welcome today's moderator, Anna Maria Barry-Jester. Anna Maria is a senior correspondent with Kaiser Health News and California Healthline, where she focuses on health disparities in public health. Throughout this pandemic, her critical reporting has highlighted the growing threats to public health infrastructure and public officials, which are captured in the Kaiser Health News and Associated Press project, Underfunded and Under Threat. And her award-winning series examines how the US public health front lines have been left understaffed and ill-equipped to handle the COVID-19 pandemic. The series also has explored the direct threats to public health officials, such as how one of our today's speakers today, Dr. Nicole Quick, was forced to get a security detail and ultimately resign as Orange County's chief health officer due to threats to her personal safety after instituting a mask mandate. Anna Maria, your coverage has been extraordinary. Thank you. And it's a great pleasure to have you with us today. So I will turn it over to you to get us started. Thank you.
Thank you so much, Donna. And I'd like to just take 2 minutes to sort of frame this conversation, elaborating on a little bit on what Donna just said, and then I will introduce our guests. So alongside colleagues from KHN and the AP, I've spent much of the last year and a half looking at the nation's public health infrastructure going into the pandemic, and then what's happened to it during the pandemic, with a heavy focus on the public health workforce that makes up so much of that infrastructure. We've found that even before COVID showed up, the nation's public health departments were already operating with a skeletal workforce. 38,000 jobs had disappeared from state and local public health departments since the 2008 recession. Budgets had also shrunk significantly in most states. So we already had an overburdened workforce in January 2020. In the early months of the pandemic, we spoke with disease investigators who were paid so little that they relied on federal benefits to feed their families and qualified for Medicaid. We talked to health department leaders who were sick in the hospital themselves with COVID, but worked right through because there was no one else to do their job. We heard from PhD level epidemiologists who were spending most of their time collecting paper faxes of COVID cases and then hand transferring that information to databases. And then as the threat of the pandemic grew, public health officials around the world, of course, took measures rarely, if ever, seen in recent times. They suspended travel, shut down businesses, issued quarantines, created mask mandates. And we all know how politically charged those decisions have been in the US. In conversations with hundreds of health officials, we've routinely heard about death threats, protests at people's homes, and police escorts. And there's been blowback from elected officials as well. In combing through thousands of pieces of legislation, we found that more than half of states have passed laws taking power away from health departments. Early last year, we began tracking the number of top officials leaving their jobs, and the list has grown to over 300 in the months since. And of course, that's just people in top positions. There have been serious losses for public health workers of all kinds. In some places, staffing and finances have become even more constrained than they were before 2020, despite all the federal money that's been made available to combat the pandemic. Federal money sent to 8 departments has been held up in state legislatures or given to police or schools. And there are many health departments where employees working grueling hours have seen pay cuts, been furloughed, or had their staff numbers slashed during the pandemic. So with all that in mind, I'd like to introduce our guest today. We have Jennifer Bacani McKenney. She is the health officer for Wilson County and Fredonia City in Southeast Kansas. She's a physician and owner of the Bacani McKenney Clinic. She's also Associate Dean of the Office of Rural Medical Education at the University of Kansas Medical Center. And she serves as president of the Kansas Academy of Family Physicians and as a member of the Kansas Health Foundation's Board of Directors. We also have Jeffrey Mangulu, who is the Director of Public Health Law and Policy at the National Association of County and City Health Officials. He formerly served as a legal and research analyst at the University of Pittsburgh's Center for Public Health Practice, where he focused on the development of legal tools for emergency preparedness. And then we have Dr. Nicole Quick, who is Chief Medical Officer of KSC Health Center, focusing on the integration of behavioral health, substance use disorder treatment, and primary care. She is a 2021 Physicians for Human Rights awardee for her work protecting public health during the COVID-19 pandemic as former health officer of Orange County, California. Dr. Quick, I'm hoping we can start with you. You had one of the most public resignations during the pandemic, partly because it happened early on and partly because of the severity of what you experienced. I was hoping you could tell us a little bit about what was happening in your life in Orange County in the weeks leading up to your resignation.
Sure. And I think that it was probably very covered widely in the news because I was one of the first public health officials to resign during the pandemic. But what was going on in California at the time is we were entering in, this was relatively early on, looking back now, in the ongoing challenge of addressing COVID in public health. And we were getting ready to loosen some of the public health measures in Orange County. And so I had deemed it necessary to institute a mask mandate. So we did not in California at the time have a statewide mask mandate. So as we were going to loosen some of the restrictions, felt it necessary to put in a safety measure of a mask mandate. Now, I want to also point out that this seems a little silly in retrospect to even say it. We had an exhausted workforce even back then when this was going on in June of 2020. And to say that now people are 2 years into this, still working crazy hours addressing COVID at local and state public health agencies. But going into this, there was a very vocal minority of individuals who were very against the mask mandate. And it was very personalized attack with protesters outside my home using some of the social networks of the school that my kids went to. So it was a very personalized attack. And this was after a series of death threats. And this was going on throughout the state of California and throughout the country at the time. So it was a matter of measuring my ability to keep doing my job with the personal attacks against myself and my family. And I want to highlight that I think that is a dangerous situation to put public servants in, to have to make a choice between doing your job and your personal safety or the safety of your family. And I also want to point out that it's still happening right now. So I find that very concerning that 2 years into this pandemic, we still have public health officials facing the same thing I did back in June of 2020.
And there was both political pressure and pushback from the public. Is that right?
Correct. There was political pressure I think that's everywhere right now. There was a lot of political pressure. And then the very, I say personalized attacks against myself and my family was public. And I do want to highlight that it's a vocal minority of individuals who felt this way, but it doesn't really matter when you're in the moment how many people are supporting you. When that's happening outside your house, it's a very real threat.
And Jennifer, I'm curious how, what you've experienced in your job has changed from the early pandemic days to now in terms of the reaction from both the public and elected officials.
Yes, absolutely. Back in March of 2020, when my health department administrator and I started doing the work in the pandemic, we didn't know any better than anybody else. We just did our research and gathered the stakeholders in our county. So my county is about 9,000 people. It's a rural community. And so, we were able to get everyone together and just say, hey, this is what we know. This is what we don't know. We started doing Facebook Live events so that we could answer questions for the general public. And at that time, everyone thought, wow, public health is great. This is, we recognize these faces and they're giving us the information that we need. And then it, as we all know, it started to change there in the summer when we started having lockdowns, and then we started trying to open things back up. And that was when we started feeling the pressure of our county commissioners saying, no, we're just going to open everything up. We don't need to phase it in. We'll be fine. Look, there's not very many cases here. That was kind of the attitude with a lot of rural communities, was that, well, we're not seeing as much COVID as everyone else. We're probably going to be fine. So we started opening up, all of the restaurants and everything else. And every time we started making suggestions about maybe even evaluating kids before they went back to sports if they had COVID, we got pushback from the county commissioners. In fact, one of my county commissioners said that was bullshit, that we didn't have the right to say that how a person should be evaluated before returning to sports. So those kind of things were just, everything that this was my expertise. This is what I do for a living, is care for people, and it was being questioned at every single level. And so for me, it also became very personal. This is my hometown where I live, so the people who are saying these things are the people I grew up with. Again, just like Nicole said, mostly supportive people out there, but the loud minority of people are the ones that caused me to tell my kids, hey, stay to the back of the house, maybe while you're at home schooling, just in case. Or that's why the sheriff's department would escort us out of meetings. And it's so much more I guess pressure on you to have those personal attacks and those professional attacks, just trying to do the work that you do. So and yes, it absolutely hasn't gotten necessarily better. I think that we are better. I personally am better at just doing the work that I know that needs to be done, and kind of pushing out the other voices at this point. But it's also hard because we in Kansas especially have had legislation, like you mentioned, Anna Maria, that really limits our powers. And so even if we try to do something, there's not a lot that we can do. Our voices are trying to be silenced by the legislature. So it's hard, but we keep doing the work that we can do.
One quick question I had was if either of you felt like you had political support before the pandemic, and also if you think that elected officials knew what your jobs were before the pandemic.
So I think that there's a wide range there. I think some elected officials certainly knew what public health was. I think a lot of people, and this is public and elected officials, were not very aware of what a public health officer did, what the public health officer authority was. I think there's a general, understanding that when public health is operating well, a lot of what we do is sort of in the background, right? And you're ensuring that restaurants are safe and that water is safe, and some of these things you're managing communicable disease outbreaks, a lot of which we don't make public for protection of privacy. So no, I think there was a general, in public and elected officials, not necessarily understanding. As far as the support, really depends on where you were and where you were working. As far as the support of elected officials, I would say, is what I've observed.
I would agree that I don't know that they knew exactly what we did and what our role was, which was just kind of fine with us before the pandemic, because we were able to do the work and not have a lot of interference. And even at the beginning of the pandemic, I think I felt a lot of support because we were doing all the hard work. We were working nights and weekends and fielding all the phone calls, and that made it easier on them. But it was later on that we started to lose that support very obviously.
So that sort of obscurity provided you some protection, but also meant that maybe contributed to some of the political blowback.
Yeah, and I want to also point out in California, for example, after many local health officers were facing sort of blowback and pushback, there were I'd say there were elected officials that stepped up and kind of made, for example, in California, a statewide mask mandate, or some of these wider ones to offer sort of a more uniformity and I'd say protection for some of the local officials. So it isn't uniform that there wasn't support. I think that's important to point out.
Great. Jeff, I'm curious from your view, working at an organization that represents local health officials across the country, whether you have a sense of if the lack of resources going into the pandemic contributed to the threats and personal attacks, like whether there was an issue with, health departments having political support going into the pandemic.
Yeah, so I mean, from a national perspective, just based on our observations and based on information that comes to us from our health officials and their staff, it does seem that the lack of resources going into the pandemic did make a difference in the amount of threats and the amount of pushback that was received by local health departments and other health departments across the nation. When you think about the fact that with the less resources that are available to local health departments and their partners going into the pandemic, there may have been, as mentioned earlier, kind of a lower profile as the health departments focus on their priority and core activities related to, their essential, their essential programs and projects. And so as the pandemic really ramped up, you notice that with a more prominent role of health departments, people really noticed a difference. I think just the fact that went from being not invisible, but kind of in the background to being the most prominent area of government in terms of response to the COVID-19 pandemic, people became much more aware of public health and became much more sensitive to the activities of health departments, at least from my perspective. And so I think with that increased sensitivity, just based on the large ramp up in activity, I think that did encourage some additional threats, some additional threats to not only the physical safety of folks who work in health departments, but also to the authorities of health departments and their ability to do their jobs, to do their function. In addition to that, I think the lack of resources really did make an impact in terms of just the ability of health departments to be able to perform some functions that would have maybe mitigated some of those threats and really would have mitigated some of the things that we're seeing today. For instance, the thing that really comes to my mind is that with health departments having to focus on certain core responsibilities, some areas such as communications, being able to effectively communicate with communities, be consistent with communications across jurisdictions and across communities. I think that was something that was not as built up based on really what the needs are that we've been seeing from our members. Folks are really interested in learning more about public health communications, how to effectively communicate, which leads me to believe that there was a lack of focus in the area going into the pandemic. And so therefore, if those capacities were a little higher prior to the pandemic, I think a lot of the concerns that we're seeing with respect to the consensus, or at least the perceived consensus, that there has been some inconsistencies in communication would have been mitigated as well.
That's really interesting that communications is one of the areas where there wasn't perhaps enough staffing. I'm interested, Nicole and Jennifer, if you have a sense of particular, specific things that with the declines in funding over time, pre-pandemic, you were not able to do to, the extent you would have liked. So yeah, I'll kind of, public health activities, whatever comes to mind, I'm interested with specific.
So I'll talk briefly about my experience. I mean, I think it's worth repeating over and over that public health has been sort of systematically defunded for a long time. And so even pre-COVID, working as a health officer, part of what everyone was struggling with was resources, and that's staff resources, money resources, and training of a competent workforce and having sort of that redundancy in the workforce was lacking pre-COVID. And then COVID comes along, and you all of a sudden as a public health jurisdiction have to completely, to an unbelievable scale, ramp up your contact tracing and disease investigation. So essentially what we had to do was pull pretty much all of our public health staff off their other duties and reassign folks to doing contact tracing, which means those other essential services that public health was working on pretty much come to a halt. And I think that in the best of times, you would have had redundancy in your workforce to be able to absorb this while continuing your other functions. So that's a very tangible and real thing that happened in health departments. Now, public health, a core function of public health is emergency preparedness. So we had plans in place, as did most jurisdictions, on how to respond to a communicable disease outbreak or another emergency preparedness. California, frequent ones, wildfires, things like that, right? So these are things that we knew how to do. And we had staff trained and we're able to reassign staff, but that really means that you are pulling people away from other duties. And I think another piece of this, the funding that came in for COVID, at least initially, counties and local jurisdictions are not always the most flexible in hiring practices and so forth. And it's not that easy when you're not having a sustainable funding source to increase public health staff, because these are short-term appointments and so forth. So when you're looking at solutions going forward, the sustainable funding piece so that you can build up a workforce that's permanent and ready to respond to future events such as this or fires or other emergency preparedness issues is critical.
Yeah, and you work for a department that oversees 3 billion people, so fairly large. Jennifer, I know you have a much smaller department, and I imagine a much smaller staff to go with it. I remember in our research, one statistic that's always stood out to me was, and I believe this was from an HO survey, but something like a fifth of rural public health workers make under $35,000 a year, going into the pandemic. And I'm wondering if there were constraints on the work you could do at the department in Kansas that due to those funding constraints, due to a lack of staff.
Yes, absolutely. So our entire health department staff is 4 full-time employees. And so you can imagine how we were strained just immediately with the pandemic. And they truly were doing the contact tracing and vaccinating when the vaccines came out. I mean, they were doing everything all day long, weekends. I mean, so it was such a strain on our staff that we actually have lost 3 of the 4 people. We're still in the process of hiring our 3rd health department administrator now because we went a long time without one. You just mentioned how oftentimes the health department staff is underpaid. The truth is that our health department administrator that I was working with at the beginning of the pandemic, she actually qualified for state funding because of her salary and the size of her family. And although she didn't do that, she most of the time held 2 jobs to help with funding her life, I guess. So I mean, really, I think that's a big testament to what we see in public health. Another example is that I know that our public health staff could actually make about, I think, $6 more per hour if they work at the local general store in town. And so why would you work for a health department at this point, right? Because you don't need the headache of that and you could actually make more money. So I think these are really real life examples of what we're seeing in rural communities, but probably in urban communities as well, that we just don't have, we've never had the funding. We don't have a large pool of people with their masters in public health. We hire the best people that are willing to work hard and care about public health, and that's really the best we can ask for. And we find great people, but now we can't. We're not finding those people now. And really, as Nicole, you mentioned like funding, during COVID and all that, we found that we had little bursts of funding that might help here and there, a part-time contact tracer here or there. In the end, we're still a 4-person health department. They are still getting paid the same amount. And that's the flaw in all of this. What have we done to correct this? How are we even going to fund the people that we have right now and continue on the work that we do?
So with emergency response money, you can't really fix that problem of long-term staff and full-time staff. That's what you need to grow the department.
Exactly.
One of the questions from our audience is how they're saying, how can we help? And I think that maybe this is on, physicians and other people in the field, help the general public see public health as a worthy occupation. And I wonder if you guys have any thoughts on that, given what we've just talked about.
I will say just very, like, one of the bright spots is that after the American Public Health Association annual meeting the other day, last month, I was approached by undergraduate students and students trying to get their master's in public health that they're ready to meet the challenge. They see what we're doing, they see what we're going through, and it's really inspiring that they still say, oh my goodness, this is what I want to do in life. And so I just commend the students that are out there that are willing to take on this challenge, because we need that workforce and we need that enthusiasm.
Yeah, Jennifer, I just wanted to piggyback on that, because at the same meeting, I was participating virtually in a session similar to this one related to authorities, and someone noted that with the current situation with public health and responding to COVID, and even the threats to authorities, there is an element of folks who think that public health is quote unquote sexy now. And so there is that interest in public health now that wasn't there before. I think that with being one of the less visible services, people just were not even aware that this was a career field. And now that they're seeing that public health is at the forefront of responding to COVID-19 and protecting our communities, there is a lot more interest in getting into the field. And so, regarding the question that came from one of our audience members, thank you so much for your interest in participating in efforts to bring more people out into the field. And I think just thinking positively about public health and continuing to spread the message organically through those that you interact with will be of great benefit to the field. And I encourage other folks to do so as well.
There has, oh, go ahead, Dr.
Oh, I was just going to add, public health, I do see that there's still significant interest in public health, and even working with our local school here, which is a school of public health and MPH students. I think one thing that is important is this funding piece and this workforce development, because there are a significant number of individuals who are interested in public health, and there's private sector jobs available that need that public health, population health expertise. But really, we need to retain this core workforce in the public sector of these individuals. So that gets back to the funding piece and this sustainable funding piece, so that local jurisdiction, well, either federal, state, or local jurisdictions can retain these qualified individuals. So I do agree that there's more emphasis right now, and there's definitely interest on public health, but it has to be paired also with this sustainable funding piece so that you can keep these people where they're needed.
That's a great point. There has been a surge in enrollments in MPH programs, but as you said, I think I've heard a lot of departments wondering whether or not they're going to be able to retain those folks. And maybe this is a question to start with Jeff, but I'm wondering if the funding from either the bipartisan infrastructure framework or what may or may not happen with the Build Back Better Act, I'm wondering if you see in there money that would help fill some of these gaps, that would provide better salaries or more positions in local departments.
Yeah, the Build Back Better Act does address some of the foundational issues. I believe that there's $7 billion or so that's going to be sent towards health departments over 5 years is a plan to really support infrastructure. However, some of that, it's what we need more so than anything else in the field of public health, is been alluded to by my other panelists, of course, is that sustainable, consistent funding, something that will remain within health departments. So we'll be able to plan out further into the future regarding, supporting staff members so that they're able to stay on the job, and the health departments are able to maintain their institutional knowledge. I think that what we're really hoping for from a nature perspective, and what we're really pushing for, is the passage of the Public Health Workforce Loan Repayment Act that we hope will really support some of these efforts. And so while current funding that's coming from Build Back Better will open up some positions in public health, we're hoping that the Loan Repayment Act will assist with the recruitment of folks into the field of public health. And so with
Can
that,
you elaborate just a little on what that act is?
Yes. And so the idea behind this act is that it would assist folks who are interested in the field of public health with the repayment of their loans that they take out in order to go through the graduate school and go through the educational requirements that are needed in order to practice public health. And so with this, we're hoping that when folks have a 3-year commitment to public health, they'd be able to gain financial support. That's really the aim of this, is to provide financial support to those who stay at least 3 years within public health departments. This act currently has bipartisan support. However, really the details of it are still being negotiated, of course, but we're really hoping from our NACHO side, from our government affairs team, to see this get passed and see this really benefit our health departments out in the field.
Great. One thing I was curious about is, and Jennifer and Nicole, maybe we can start with you, is how you had used your public health powers before the pandemic. I think, as we've discussed, a lot of people weren't really aware of the authority granted to public health officials pre-pandemic. It was used usually in relatively rare occasions. And I'm wondering if there were circumstances when you'd used your public health authorities before the pandemic.
Do you want me to go first?
Sure, go for it, Jennifer.
Mine's pretty simple. Before the pandemic, I signed a lot of vaccine protocols. I did, we did some grants on breastfeeding and smoking cessation. I inspected a lagoon one time. To be quite honest, I think I became the health officer the way many of us rural health officers got this role because the previous one died and they needed somebody to fill the spot. And that was kind of the training, the on-the-job training to say, hey, we think that you can do this, and we'd like you to lead our public health efforts in the county. So prior to this, it was much different. It was still a lot of good education and work throughout the county, but a much different story.
And I'd add there, in my experience, I worked before Orange County in a small rural northern county as well. So I'd say that I definitely had experience using public health authority for communicable disease outbreaks and largely TB. So mandating sort of TB treatment, controlling that. Restaurants is a critical one. So the delegated authority that's through health officers that we generally delegate to environmental health. So protection of restaurants and closures of restaurants for, let's say, hepatitis A outbreak or some, salmonella. That was an ongoing public health authority. I'd say that I used frequently, but that's very, I'd say, under the radar and behind the scenes. People expect that their restaurants are going to be at a certain level of cleanliness and so forth. So those were things that a lot of health officers' authority was used on an ongoing basis, but certainly wasn't as visible. There were some exceptions where there was more visible public health authority, I'd say in California, for a lot of us, having to do with wildfires and needing to declare areas where our cleanup crews can go onto property and so forth. So those were times where health officers would issue orders. Mandates for flu vaccine in given jurisdictions is another common one, but these were things that were certainly less visible to the public than doing a countywide mask mandate or a vaccine mandate or shutting down businesses. So there was these protections going on and have been going on for a long time that the health officers have been doing.
With the trend in legislation that is pushing back on some of those powers, in some states, the laws are written as reactions to COVID and are specific to COVID, but there's a lot of laws in there that are much broader than that. Many that sort of reduce quarantine powers, which, as you said, are routinely used for, but also rarely used for infectious diseases. I'm curious if there are, if you're concerned that any of the new legislation will affect your ability to work on either other public health issues or other emerging health crises we might not even know about yet.
The answer for me is absolutely. It's a very dangerous precedent to be taking these public health authorities. The isolation and quarantine, we've had that in statute for a long time for good reason. And I think TB is a critical example of that. Public health has been tasked with TB control for a long time. And part of that does involve, in some cases, an isolation or quarantine, as do other communicable disease outbreaks. And so I do think setting the precedent of taking away these public health protections or powers of authority for public health has vast consequences, including environmental health, which is huge. So it's worrisome.
Jennifer, are there concerns you have?
I would absolutely agree. Yes. I think the thing that I learned through the pandemic, I guess the hard way is that as we see, I guess as things happen, as this legislation gets passed, I mean, really, I will just very bluntly say the wrong people are making the decisions when it comes to public health emergencies or any type of healthcare decisions that need to be made. I mean, I'm on the local school board, and our school board is deciding more things about how we're going to keep our kids safe than I, as a public health officer, do, or our local primary care doctors or hospitals. So our school board that doesn't have medically trained people on it besides me, they are making these decisions, not taking my advice on the decisions. And as was very evident from the recent elections, I mean, at least locally and across my state, a lot of people were getting elected that held very strong stances that I would perceive as being anti-science or anti-mask or vaccine. And so for me, it's very scary moving forward that these are, we're hopefully going to get to a place with COVID and this pandemic that, it is what it is. We know how to treat it. We know how to vaccinate. We do this, but these elected positions are going to stay on longer to make these, it's not all about COVID, so we need the right people in the right places for the right reasons, not just because we're angry and sick of a pandemic.
And Jeff, are there trends in this legislation that you're particularly concerned about?
Yeah, I mean, the biggest trend that I'm seeing in the legislation is not only that legislation that impacts the response to the pandemic that we're currently in, but extends beyond the pandemic into other authorities, abatement, into environmental health enforcement, into restaurant inspections or other inspections or licensing. You're seeing that there is a scope creep of sorts in terms of kind of the erosion of authorities beyond those that really deal with infectious diseases. For instance, some jurisdictions, you may see a shift of enforcement on restaurants moving from the health department to elected officials, things of that nature. And so that's the trend that really does worry me, as it relates to what Jennifer noted. You're seeing these decisions in the hands of folks who don't have that scientific background, or might be even in some extreme cases anti-science. And so you're seeing that some of these protections that have been in place in our communities that have really benefited our community members might be going away, or might be eroded to the point where people start actually seeing oh, injuries are occurring because health departments aren't a part of this process. Those health departments that we may not have noticed were really integral to the protection of my health and the health of my family members.
So in talking to some of the legislators who crafted some of this legislation, they describe it as this is sort of an improvement of checks and balances, that they want elected officials to, are elected and accountable to the public, and they want them to be able to have a say. I'm curious if you can elaborate a little bit on how that affects the work of public health in terms of being able to respond quickly to a pandemic, or or to whatever emerging health threat there is, or why that might create a problem for public health to have sort of the ultimate authority in the hands of elected officials as opposed to scientific experts.
Yeah.
You want to start, Jeff?
Yeah, I'll start with some of my impressions, though I believe Nicole and Jennifer will probably have more tangible, examples of this. However, really, for me, the big concern is the ability to act in a quick and decisive manner is being, being reduced. And so for those areas where the harm that can be impacted on the community can be reduced if you act more quickly and decisively. There's going to have to be now some additional steps before you could take those actions that would really have those benefits to the community. And so therefore, there might be some additional harm that takes place for the community. In addition to that, sometimes those actions that would be a benefit to community members may not even take place if it's decided from a political perspective that they wouldn't be beneficial to the potential reelection or career advancement of someone in a position that really is of political nature. And so those are my first two observations. I'd love to hear what Nicole and Jennifer have to say though.
Yeah, clearly there's the reason there is the ability for health officers to do a health officer order that would restrict someone's freedoms in the case of a communicable disease outbreak is because it benefits public health. And the reason that this process is the way historically it was is you have to act quickly, right? If you need to restrict somebody because they're going to spread a communicable disease, or there's a threat to public health from a natural disaster and you need to close something, the reason you have that ability is to do that quickly to protect public health. So if you put those decisions into outside of the control of the expert who has training on it, you're going down the wrong path. I mean, I think it's very obvious that people don't go to elected officials to get surgery, right? You're relying on a physician that has training in that, and that's what we do. And we should be doing the same for public health. There's a reason public health officers are in place. They have dedicated professional training and experience to manage these threats to public health, and we need to retain that power in the experts that have that.
I always think it's interesting because because checks and balances have always existed actually in public health. So we're appointed, right? So we're not elected. They technically the commissioners or whoever appoints us can fire us too, right? And so that's kind of something that's always we've always reported to them. And so taking that to a whole new level seems very unnecessary. I think to say not only can we fire you or will we fire you, but we also think that you shouldn't be making the decisions that you're able to make, or even sometimes we don't even want to approach you for advice, for medical advice. We'll make the decisions. We'll let you know if we need you. That's kind of the message that public health, at least in my state, is getting, that like, hey, good to have you there, but we'll contact you if we need you.
I wonder if any of you think differently about public health powers now than you did before the pandemic. I've talked to some health officials recently who've been really excited and proud about the way they've been able to use their health authority to protect workers, to sort of look at specialized populations and figure out creative ways to protect them while also trying to keep the economy open, things like that. I'm curious how it's changed your perception of those powers. I'm assuming that has, because you've used them differently than you had in the past. Maybe Jennifer, you want to start?
Yeah. I mean, definitely it's very different. And I will say there's a reason that I am still here, that doing this work and truly it's because it's my hometown and these are the people that I care about, and these are my people and family and friends that I grew up with. And I do feel as though I want to continue the work to keep the people safe that want to be kept safe, to want to be healthy. So I don't want to stop doing the work of public health simply because of all the negativity and the politics out there, and not all of my colleagues have been given that opportunity. I mean, really, because it is bad. Like Nicole said, you shouldn't have to choose between doing the work that needs to be done and safety of your family and yourself. So that's a sad place where we are. But I will say my view on public health is much different. I think it's so important. I think about public health in such a different way as far as the many things that we do are public health, whether it's on the school board or whether it's just education or writing about something in the local newspaper. We can be doing public health in many different avenues, but it is such important work, and I'm proud of all of our colleagues out there who have been doing this throughout the pandemic, because it's not easy work, and it's hard personally and professionally.
Yeah, I think I have an even greater appreciation of the critical role that public health and public health officials play in the health of this country after COVID, through COVID. And I think that I have a greater appreciation of I think what's needed is more policy level changes to ensure that the decision powers actually still rest with the experts. So I think that's what I feel at this point in the pandemic. And we've talked already about this, that the trend's going the wrong way. And so we need to ensure that the experts that are still there or attracting new people who are willing to do this for work, that they have the ability to continue to exercise their public health authority. I also just briefly want to touch on, because this came up earlier, but I think it's critically important to this, the communication piece that is critical. And that crisis risk communication training that public health officials go through, critically important. And the fact that the public was getting different messages from federal, state, and local health officers throughout this really created part of this public distrust and so forth. So, public health authority needs to stay with public health experts, but we also as a country need to do better at how we communicate about this and to try our best to have sort of uniform communication and messaging to help the public understand why it's critically important that these public health, authority exists and what it's used for.
That's really interesting. Lessons taken away from this. Jeff, I wonder if you've focused on policy and public health law for a long time. Are there things that you think differently? Or has this experience changed your thoughts on those things in any way?
Yes, I mean, I think really, and Nicole brings it back up, the communications piece and the role that communications plays in policy. And like that, I mean, communicating to those in the community who are putting the folks in the elected position to change the policy and adjust the policy that does impact the authorities of health departments. Having that more kind of grassroots view is something that I've always had an awareness of, but really the critical aspect of that activity really has been amplified by the pandemic. Folks, the decisions that are being made by elected officials are those that they perceive to be the most popular, those that they perceive that the people want and desire. And so being able to communicate effectively to the community as to why these decisions are being made and the impacts, the positive impacts that these decisions have on their health and the health of their neighbors and family members, I think would adjust really the response that we've seen to public health authorities throughout the pandemic. And people be perhaps, maybe I'm being too optimistic, but they'll be more welcoming to the interventions that have taken place if there was better communication at the outset and more consistent communication at the outset. So I think that that's probably the biggest kind of takeaway I've received since the pandemic started.
And I think I understand you saying consistent communication, but also that because public health is so decentralized and happens so much at the local level, that people need to be hearing consistent messaging from their local representatives, the people they're hearing from directly.
Yes, and I believe that that's critical throughout all the jurisdictions throughout the country when you think locally. But I mean, especially having effective communication abilities and really remaining in communication and conversation with community members at more rural locations, especially, I think would have been of greater benefit. And that's where you see kind of the resources issue taking place again. Dr. McKenney noted that there's I'm sorry if I'm getting this number wrong, but about 5 folks within your health department or so. And so the ability to kind of spread your scope to having someone who's able to have consistent messaging with the community prior to the pandemic probably wasn't there. There are health departments out there that have like 0.5 FTE. So someone with a part-time job is the only person with the health department, and their ability to communicate effectively with folks within the community as to the importance of public health really isn't there. It's not possible the amount of time that they have. And so it's all kind of related, unfortunately. And that's why we keep saying that having that sustainable funding to really support the efforts and bring folks into the health departments to really support these initiatives would be of huge benefit from not only a programmatic perspective, but also a policy perspective as well.
We have about 5 minutes left, and I did want to ask of all of you, what resources are most needed right now? Maybe we can start, Jennifer. Obviously, the rural settings, as you've mentioned, it is such a different thing. You know, it's a small community. You can't imagine there's going to be a giant health department in terms of the number of people there, but that, you know, of course, the resource needs are also more severe in some ways. I'm curious what the resources would help you right now and doing your job, both in, you know, combating COVID-19, but also, you know, dealing with other health issues, of which there are many.
Sure. I think we need many resources probably at this point. Money and staffing really is the biggest thing, and just paying our public health workers better. I mean, I think that's just a thing that we need to do across the board. Yeah, something that will allow us to be, or funding that will allow us to sustain what we have and actually grow so that we can actually do more public health work in our county and in the region of our state. We're always limited by, you know, our people can do exactly what they can do until we get more people in there to do the work. We can't even apply for a grant because we don't have someone who has time to apply for the grant, you know. So how do we continue to grow without that kind of support? So I think financial support, and I just think support, community-wide, legislative support, just to say, you know, public health is important. And obviously we've talked a lot about how we're not seeing that at this point, but those things have to happen before a community like mine can do more with public health than just keep fighting the pandemic.
And Nicole, it's interesting because you know, worked in the public sector, but also now are working at a clinic, and, you know, everyone talks about sort of the need for all these things to work together in public health. I'm curious from where you sit now, what resources you see as sort of essential going forward to be able to deal with all kinds of public health issues.
Yeah, I luckily, the clinic that I'm working at now, I worked with on the other side when I was in the public sector, and we're part of sort of a safety net health system, particularly for some of our most vulnerable, which are the homeless and the jail reentry. And what I see for on the public, I'm happy to still answer that from having worked in a small rural and a large urban public health department. It is definitely the sustainable non-categorical funding. And public health is, you know, public health's role is much greater than communicable disease control. So when we're talking about equity in health and wellness, public health serves a critical role and can do so much, but there really needs to be a workforce that's able to respond to what the community needs and be responsive to that. And that's sometimes hard when you get very categorical funding that may be grant related, or it's, you know, funding specifically, let's say, for congenital syphilis, which is all very important, but we need to build a workforce that's sort of nimble and responsive, but you have to know that the funding's still going to be there. And I think that's both in urban and rural areas. And I think that the other piece of this is to be able to retain and keep a skilled workforce. We also need to re-elevate the voice of that expert, right? So the staff needs to know that they'll be able to do their job and that they're going to be listened to and that they're not going to be put in harm's way, and that they can do their job really with the support of the community. So I think that's another piece for going forward to make sure that public health is in the position it needs to be.
And Jeff, you mentioned the like loan repayment program for people in the workforce. I wonder if there are other legislative things that NACHO is pursuing.
Yeah, I mean, we're trying to continue to identify that sustainable funding from a federal level. We're working with the CDC and other federal agencies to think through how we could better support our health departments as they respond to the pandemic and beyond. So we're seeing sustainable improvements. So, you know, with the current state of the pandemic, health departments that we've noted have seen some additional funding. And so we're trying to think through creatively how we're able to sustain the efforts that have been and sustain the gains that have been able to be made in some of these jurisdictions based on the additional funding that's been taking place or has been received. I think that really with a lot of the activity that we are trying to pursue in the space of providing resources to our health departments to really support them. We are trying outside of our activities in government affairs to really gain that funding is, you know, try to provide that consistent voice for our local health departments, at least through the creation of things like policy statements and sending letters on behalf of our health departments to agencies and folks at a federal level. Thinking through resources that we could create also to support our health departments has been a focus of ours as well. So I think one of the biggest areas that we're really trying to see improvement is related to administrative preparedness, so improving processes at health departments to bring on staff and retain staff, to procure supplies, and also just streamline those administrative activities, as well as creation of tools to help with the resilience of their workforce and staff, and also capacity workforce and staff. And so trying to create tools that could really assist folks from a mental health perspective to deal with a lot of the pressures and stressors that we discussed today. And just thinking creatively with our partners as to how we could better support our health departments and their staffs in order to be able to continue to provide the excellent service and work that they're doing in our communities.
Great, thank you all. I feel like in some ways we've only scratched the surface on this topic, but unfortunately our time is up. So I'm going to turn it back over to Donna, but thank you so much for this conversation. It's been really interesting to hear.
Oh, it's been an extraordinary conversation. Jeff, Nicole, Jennifer, and Anna Maria for moderating this discussion, bringing it all together. It's been so informative. You know, the protecting health, public health officials and institutions has been, since PHR's founding, a core issue of importance to us in our work. And there's the fundamental need to ensure everyone's right to health and the benefits of science as a health equity. And this conversation today was both sobering, thinking back to nearly 2 years ago. And as you said, Nicole, these are situations still happening now, but also inspiring because you bring to this, all of you, your wisdom and your insights on policy level decisions. And that just impact the lives and safety of our communities. And I also want to point out your selfless dedication to public health and human rights. I hope you're right that there is a budding generation that will follow also in your footsteps, because you certainly inspired me, and I'm sure you inspire them. And just lastly, as we continue this panel series at PHR, we will continue to bring experts together with conversations that are focused on building a more equitable future in public health and human rights. We at PHR learned from all of you, and these discussions actually continue to shape PHR's response to the pandemic. So thank you for being with us today. And for those who joined us on our webinar, we want to hear from you. We want to hear the topics that you're interested in and your ideas and questions, because they shape our panel conversations going forward. So you can reach out to us at webinar@phr.org. And just something else that people can do, we will share today's conversation on PHR's website within the next few hours. And you should share it with people who would be in a position to influence policy and change hearts and minds. And you can also check out our website for recordings for the entire series and information about upcoming discussions. So thank you all. Thank you especially to our panelists today. We're so grateful to you for so many reasons, and wishing everyone a great weekend. Thank you.